Welcome back. Harshal here, your enthusiastic and focused explainer, ready to decode the complex CPT codes for behavioral health management. We're jumping right into a highly requested, absolutely crucial topic from our CPT guidelines today. We are unpacking Part 48, which covers General Behavioral Health Integration, or BHI, and the Psychiatric Collaborative Care Model, better known as COSIUM. If you've ever found yourself totally overwhelmed by the different team roles, the strict time thresholds, or the CMS guidelines surrounding these codes, you are in the exact right place. Let's get this all crystal clear. Here's our quick game plan for today. We'll set our general BHI baseline, break down the COSIUM framework and its core team roles, do the math on those time thresholds, and then wrap it all up with the anti-overlap guardrails. All right, Section 1, let's establish that general BHI baseline. So CPT code 99484. This is all about non-face-to-face care management directed by a physician or qualified healthcare professional. We use this for patients with mental, behavioral, or psychiatric conditions. And yes, that absolutely includes substance use disorders being managed right there in a primary care setting. The absolute golden rule you need to remember here? It requires 20 or more minutes of clinical staff time per calendar month. Now, what actually makes up those 20 minutes? It's not just a casual phone call to say hello. The core activities require a structured initial assessment or follow-up monitoring, specifically using validated rating scales. You've also got to systematically track a behavioral health care plan and coordinate treatments like psychotherapy or pharmacotherapy with the rest of the care team. It's real, structured management. And here is the real kicker with 99484. Unlike the more complex models we're about to dive into, this operates completely without the requirement of a dedicated psychiatric consultant. This is standard primary care integration, where the primary treating physician, or QHP, is managing the patient's behavioral health directly, utilizing their clinical staff. You'll want to keep that distinction firmly in mind.
Moving right along to Section 2, let's explore the COSIUM framework.
COSIUM really levels up the care for patients who just need that specialized, multidisciplinary oversight. Think of a patient, let's call him John, whose depression just isn't budging under traditional management. COSIUM brings in a highly structured team approach. It's delivered by a primary care team, a designated behavioral healthcare manager, and a psychiatric consultant, all working together to get John back on track. The CPT manual is super specific here, stating these services must be provided under the direction of a treating physician during a calendar month. The whole framework is literally designed for continuous proactive engagement. It utilizes evidence-based brief interventions and registry tracking so patients like John simply do not slip through the cracks. Let's get into Section 3. To code this right, we need to know the core team roles in COSIUM. It's a three-part dynamic. First up, the treating physician, or QHP. They direct the overall care, oversee the medical management, and they are the ones who actually prescribe and monitor the meds. Second, you have the behavioral health care manager, or BHCM. They are the primary point of contact for the patient. They provide those brief interventions, maintain the registry to systematically track progress, and handle the day-to-day engagement. Finally, the psychiatric consultant periodically reviews that registry with the care manager and advises on how to modify the care plan. Now, this next detail trips up coders and providers all the time. The psychiatric consultant typically does not see the patient face-to-face. They also don't prescribe medications directly, except in very rare circumstances. Their role is strictly consultative. Because their time is already baked into these CCM codes, they don't bill standard EM codes for these weekly caseload reviews. Section 4 is where we do the math. Let's look at the COCAM time thresholds. Month 1 is always the heaviest lift. For the initial month of collaborative care, CPT 99492 applies, and this requires a threshold of the first 70 minutes of behavioral healthcare manager activities. This higher time requirement completely makes sense when you think about the outreach, the initial assessment, building the individualized treatment plan, and getting the patient entered into the tracking registry. For any subsequent month of care, you drop down to CPT 99493. This one requires a threshold of the first 60 minutes of care manager time. In these follow-up months, the focus shifts. You're tracking follow-up progress, doing ongoing weekly caseload consultations with the psychiatric consultant, monitoring outcomes with those validated rating scales, and continuing to provide brief interventions.
But what happens if your care manager is heavily involved and spends, say, 100 minutes in a month? Well, that is exactly where our add-on code comes in. If you exceed the base minutes in either the initial or subsequent month, you use the add-on code 99494 for each additional 30 minutes. Also, a quick but critical side note for your Medicare patients. There is an HCPCS code G2214. This is a short service option for either the initial or subsequent month, covering just the first 30 minutes of care manager time. It's essentially a pathway to bill if you fall short of those 60 or 70-minute thresholds for Medicare.
The manual actually provides this fantastic, strict blueprint for knowing exactly when to apply the base codes versus the add-on codes based on total time. To cross the threshold to bill 99492, you must hit the midpoint of 36 minutes. To bill 99493, you need at least 31 minutes. There's really zero guesswork involved when you are tallying up that time on the last day of the month. So practically speaking, you want to follow these structural steps at the end of every calendar month for perfectly compliant time-based billing. Step 1. Aggregate all the distinct, non-overlapping behavioral health care manager minutes. Step 2. Select your base code, 99492 for month 1 or 99493 for subsequent months. And step 3, check your remainder minutes and append 99494 for any additional full 30-minute blocks. The formula is simple, but strict adherence is an absolute must.
Finally, Section 5. Let's cover compliance and the anti-overlap guardrails.
First, an absolutely crucial note on initiating these services. For patients who are new to your practice, or maybe they just haven't been seen within the last 12 months, you must have an initiating EM visit before you can begin billing these monthly care codes. That could be an annual wellness visit, a standard office visit, or transitional care management. Now, regarding co-billing, you actually can bill BHI or co-CM alongside chronic care management, or CCM, and remote patient monitoring, RPM. But the time and care plan elements must be strictly distinct. You cannot double dip and count the same 10 minutes of care coordination toward both CCM and BHI. And when it comes to general BHI versus co-CM, the guidelines are crystal clear. Do not report 99484 in conjunction with 99492, 99493, or 99494 in the same calendar month. You cannot bill both the general BHI code and the specialized co-CM codes for the same patient at the same time. You simply have to choose the model that best fits the patient's current acuity. So I want to leave you with this question to really think about. How will you optimize your clinical tracking to guarantee compliance with these strict calendar month thresholds? You have to think critically about your operational workflows here. Are your behavioral health care managers documenting their time daily? Does your EHR actually aggregate this time and warn you of overlaps with CCM? Ensuring you aren't leaving allowable revenue on the table while simultaneously avoiding those dreaded overlap audits? Well, that requires some really solid proactive system design. Mastering these behavioral health integration codes is a huge win. It allows your practice to be rightfully reimbursed for the massive amount of coordination it really takes to treat the whole patient, physically and mentally. I hope this structured look at the source guidelines gives you the absolute confidence to apply them accurately in your workflow. Stay compliant, stay curious. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.